Then coming to the non-obstructive azoospermia, there are conditions wherein the sperm production itself is affected at the testis. They are called spermatogenesis defects, which may be a complete development of the spermatic up to the dead spermatid and then nothing more. And this is called sperm maturation arrest. And there are situations where the entire spermatogenesis is not there, but the Sertoli cells alone are found lining the tubules. That is called Sertoli cell only syndrome. And there could be fibrosis of the entire testis, and even in these cases of sperm maturation arrest and fibrosis and Sertoli cell only syndrome, even though it appears discouraging, there could be occasional islands of cells wherein the sperms could be retrieved. That is why when you are doing the sperm aspiration from the testis, we resort to micro-Ts, wherein the dilated tubules from the testicular tissue is individually examined, teased out for the presence of sperms. And even those sperms are adequate for ICSI. And the cases where there are no sperm, cases where there is no possibility of producing ICSI, alone we have to think of other options. And then what about the role of hormones in azoospermia? Hormones in general are not very useful for men with azoospermia, except for cases of primary hypogonadotrophic hypogonadism, which means lack of secondary sexual characters, small sized testes, and absence of sperms. And in such cases, there is a place for hormones. What about genetic tests? Genetic tests are employed in suspected cases of Klinefelter syndrome, wherein there is an extra XXY chromosome. He is brought up as a male and he has got a bilateral gynecomastia, enlargement of the breast, and both the testes are small and semen analysis showing azoospermia. Now, with our current methods of ICSI, there are very few cases which cannot be considered for ICSI. And irrespective of the size of the testis, the previous biopsy reports, and high FSH, we can take these cases and offer them a solution by producing biologically their own child, without resorting to any other option like adoption or donor sperm insemination. This is a wonderful change in the treatment of male infertility, regularly employed. There are people who question whether such children born through ICSI will be normal. We have a large series of patients and couples treated with ICSI, and in our own experience we find there is hardly any birth defect in ICSI. It is as much normal as the normally born children. So it's a wonderful opportunity. Only thing is, you require a team to work with, the urologists or reproductive urologists we call it, or the genitourinary surgeons who are also urologists, to identify the proper cases and to select cases for microepididymal sperm aspiration or microsurgical recanalization, and then such of these cases will have to be correspondingly, they have to be seen by the gynecologist for the female and the embryologist who will perform the procedure in the laboratory. And these embryos in the blastocyst stage can be kept frozen and used for embryo transfer at a later stage. And this is a regular exercise which is being carried out successfully at Mark. And we offer them very reasonable, affordable form of treatment with HC at Mark.